So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
PharmD ED, and I'm bringing you another episode of the Pharm So Hard Podcast. We have another special episode, and I'm super excited, as always, guys. We're going to be talking about the treatment of UTIs, particularly in the ED. And you guys know it's me, Jim Pruitt, aka PharmD in the ED, and I'm ready to move this podcasting and all this in a new direction. But a few announcements before we get started. If you haven't registered for the Empower Conference and went to that, you're in luck. We actually work with our partners at the University of South Carolina, and we are allowing you guys to go back and get the entire conference. If you just want to watch it for free, that's fine, it's there. But if you guys want continued education credits, we have it available for you as well. So we have it now as home study, so please go ahead and check that out. But let's go ahead and jump into this episode. I have a phenomenal guest, and I'm not going to try to butcher all of this and all of the background and how amazing she is. Go ahead and introduce yourself for the audience.
Hey everybody, my name's Claire Milam, and I am one of the new clinical instructors here at the Medical University of South Carolina. My hometown is actually Lebanon, Indiana, but I came down south to do my medical training in emergency medicine at Carolina's Medical Center in Charlotte, North Carolina, and then I'm down here, working with the residents and also doing a global health fellowship. So super excited to be here and talk about UTI treatment.
Well, let's go ahead and jump right into it. You guys know that these patients come in every day, no matter how big or how small your ED is. But let's go ahead and jump into a patient case. Let's say we have a 42-year-old female that presented from home with a chief complaint of cloudy and smelly urine. She's concerned that she may have a UTI. She denies dysuria, hesitancy, frequency, abdominal pain, fevers, chills, nausea, and vomiting, or discharge. However, she has a UTI. She had a UTI 2 years prior and presented with dysuria and frequency. Her vital signs are normal, and she displays no abdominal tenderness. So your nurse is in triage, already obtained a urine dipstick, which shows us a white count of 2, negative nitrates, trace leukesterases, normal pH, and negative less than 5 squamous cells. So from that's our case to start off with. As we go through this entire presentation, I want you guys to keep that in the back of your head. So before we even get too deep into this, Claire, tell us, why is this topic even important?
Yeah, so we see this patient all the time. And so I think it's really important to be able to navigate exactly, what we're looking at with the urinalysis, what symptoms we're looking for if we're actually concerned about a UTI, and then, what is the appropriate treatment if we think that that's what's going on. But I think this is also important to talk about, because a lot of times in the emergency department, we're guilty of ordering urinalysis on patients that don't really need it, and really kind of over-treating things that aren't really a UTI. So kind of, again, navigating what are the symptoms that I should be ordering this for, and then kind of going into really who should we be treating so that we're preventing, worsening antimicrobial resistance and all of the other things that I'm sure you love talking about.
Perfect. So again, I think a lot of this, I want to take us down this pathway, and now we have this patient in front of us. We know why this topic is important. I want you to drive us down your workup. And I think that this is going to be great for pharmacists. It's going to be great for our nursing staff, great for our providers that are listening, because we should just have an understanding of what everyone's doing and what's important during this workup, so that from a pharmacist standpoint, we're looking in the chart for these things, or we're at the bedside with our providers if we're in a shop that does that. So walk us down your thought pattern. What are you going to teach your residents? What are you doing? What do you want when working with a patient for a UTI?
Sure. So the first thing that I generally ask my residents when they come to present is start off with their pertinent past medical history, right? So do you have a history of urinary tract infections? Have you had any recent antibiotic use? Have you had a history of complicated urinary tract infections? Any instrumentation? Anything related sort of to the GU tract that could affect our decision making? And then after that, physical exam, always starting with vitals, right? Do they have a fever? Do they have any tachycardia, any hypotension, any signs that they have some worsening infection that's causing vital sign abnormalities? And then, of course, kind of like you said, what's their exam? Do they have a bunch of suprapubic tenderness? Do they have flank tenderness? That CVA tenderness that everybody kind of, how hard are you hitting them that they jump off of the bed because they actually have CVA tenderness? And then kind of moving from there is the lab, right? So who should we be getting a urinalysis on? Which, again, this is something that has been discussed for a long time in the ED literature and in a bunch of, PhoMed podcasts and things like that of like, who should we be screening? And something that I like to talk to my residents about is like, do they have symptoms? So if they don't have symptoms or they're not frankly septic, we really are screening too many people inappropriately. And then they come back unequivocal, and then what do you do?
Yeah, that's the big thing. I think that we see so many cases where people are getting worked up for a UTI, and it's like it's part of it. And then more commonly what I see is if they're coming altered, we're going to get all of the labs, and we just happen to also get a UA. We happen to also get a culture. And then for me, I do culture callbacks. So I'm seeing these patients where I'm looking at the note. There's nothing mentioned on the physical exam. There's nothing mentioned in the history. But we now have a culture that has bacteria that's there. And I'm having to decide, did you just not mention it? Or is it something that's done? So I think even when writing your note, is saying these are the key things that I want to make sure that we have documented. And these are the key things I want to make sure I'm ordering if I'm actually looking for a UTI. But a lot of times we're doing it and we're not necessarily looking for a UTI. We're just ordering it just to order it.
Right. And the thing that's difficult about that altered patient is, one, how altered are they? Are they like truly acutely encephalopathic and altered to the point where you think they have a systemic infection going on? Like, that's probably the right thing to do to see if they truly can't answer anything and, again, are showing signs of systemic illness to say, could that be a possible source? While also checking for other sources, as opposed to the person who comes in that their family member's like, I don't know, just like a little bit more confused, maybe a little bit of delirium. Yeah. Those are the patients that it's, kind of a gray area, but we have strong recommendations, not only from, the Infectious Disease Board, but also, ACEP and all of the kind of governing bodies of emergency medicine who say, really, it's okay to potentially screen them, but look for other sources of infection, and watchful waiting is really the best thing. Yeah. It should be a diagnosis of exclusion.
Absolutely. And that's really the big point, and I'm asking my docs, especially because now I've worked with many providers, and I say, what's the thing, what is it in the exam, what is it in the labs that make you treat versus not treating? Mm-hmm. So that's the big question I have, like, what makes you treat versus not?
Sure. So, I would say if it's somebody who is symptomatic, treat them. Yeah. Right? Like somebody comes in and they're like, hey, it burns when I pee. Mm-hmm. Treat that person. Yeah. Absolutely. For the kind of person who's like, oh, I don't know, I just feel like a little bit more tired than normal, like that terrible dizzy complaint that we all hate, I would say potentially not treat them. If they're to the point where you think that everything else is negative, they're going home, I would wait and not treat that because really data has shown that you don't improve anything by treating them, even if you clear their bacteria, and you're actually putting that at increased risk for C. diff. And there's actually some data out there that says, like, after treatment for a UTI, a supposed UTI, you're actually increasing their risk of getting another UTI because you're clearing them of kind of their safety bacteria. Yeah,
and that's the thing I think we forget is like our microbiome. Like bacteria is not necessarily like horrible everywhere. Mm-hmm. There's going to be some bacteria there, and especially depending on the sample that you're getting is also something to consider as well. So I think the symptoms are really going to be treating versus not. Mm-hmm. And the next thing that I always ask, I think is really unique. What is this mysterious positive UA? Because that positive UA gets more treatment than anything.
Right. Well, before we get into the positive UA, there's also another patient that I would treat for a UTI, and that's again the person who comes in with signs and symptoms of systemic infection, and we don't have another source, right? So that person, yes, admit them, start broad spectrum antibiotics, and consider that it could be a urine a urinary source. Okay, but the positive UA.
Yeah, it drives me crazy.
Right? I mean, I think that's so hard because you have so many reasons to have either false positives. Maybe the urine's just been sitting there for a little while, because if it's been sitting there, it's going to increase and you're going to get like leukosterase there. Maybe it's not a super clean sample. So many reasons that it could look, quote unquote positive, but realistically, a urinary tract infection is a clinical diagnosis. And so looking at a lab without looking at the patient, it's not going to help you.
Yeah, I commonly see is like, oh, there's some white blood cells there. There is like 2+ nitrites, and it's like I gotta do something because the patient has generalized weakness. It's very challenging. I would definitely say that, but it's like I always ask myself, like, do all these things line up? And it doesn't necessarily always do. In our patient, let's say that we have none of those things. We have no symptoms. We have none of the labs so far, and that's something that really is intrigued me. And I think that really brings us into our next question, like mistakes that you see commonly. Now, you've mentioned it a little bit before, but like, what is the most common mistake that you see, even from working these patients up, even before the treatment stand?
I would say the most common thing is ordering a urinalysis when you don't need one. It happens all the time. And then sort of after that, I would say, again, treating those patients that are not actually having symptoms of a urinary tract infection. And I get it, because we want to do something for these people, and it's like, oh, you're feeling bad and I don't have another answer, and so I want to give you something to make it, make you feel better, make me feel better, regardless if it's really helping them or not. And then, I would say I was looking at a paper that says, like, other common mistakes are giving them the wrong antibiotic, giving them, specifically for like the antibiogram of your region, giving them the wrong antibiotic for their creatinine clearance, giving them the wrong duration of antibiotic, right? Like, they probably don't need to be on an antibiotic for 14 days. So, I think everybody goes in with good intention, but we, sadly, I think, overtest, overtreat, treat incorrectly. Yeah,
and I think even we talk about the UA, but then even the culture that we get after that, that's another thing that a lot of my ID colleagues tell me, Jimmy, I don't know why you're getting all these urine cultures, but again, just the culture of what we do, unfortunately, most of it, you don't even order. Sometimes it can just be a reflex culture.
Right.
So like if it shows anything there, it's automatically going to do it, and you don't necessarily have that high end differential. And then 2 days later, I get the culture for E. coli that's like pan sensitive, and I'm like, okay, do I go back and see if they need to be treated? And what I usually do is I call the patient and say, hey, how do you feel?
Right.
Are you having any symptoms of, a urinary tract infection? But I always like the caveat, like, how are you feeling right now? And just leave it open. Right. Because if you say, are you having UTI symptoms, there is that patient population that's going to say, actually,
my urine is cloudy.
Yeah.
Which I think we didn't really discuss, but that's not a symptom of UTI. That's, the way that it smells, the appearance of it is more like, what's your hydration status? What are you eating? What's your diet? As opposed to, is it infected?
You commonly get somebody gets some urine. It's like, oh, it's a dirty sample.
It looks dirty.
It looks like a UTI, and it's like, it is the common.
I mean, it's like, maybe, but
we'll look into it deeper, and I think a lot of UAs are drawn from that conversation. Oh, it smells this way, it does that way, but we have no actual symptoms that's leading us that on our exam, especially for a patient that can communicate with us.
Sure, right.
We're so used to patients who unfortunately can't communicate well with us that if we have those patients, we really have to keep that in consideration. So,
sure. Well, I like that you call them and ask them, like, how are you feeling right now, right? Because I would say that not all emergency departments have other people who call back their cultures, and I guess I would presume, I suppose, that it's a lot easier sometimes to just look at the positive culture and write the prescription, right?
Yeah, it's challenging. That's why I keep saying we have to. Pharmacists in the ED are like grocery stores. You don't need them, but it's sure as heck convenient to have.
You want them.
you prefer to have it there.
It's more than just convenience. Yeah. It's like, please help me.
So when I call and I get whether they have symptoms or not, and then from there I can take this information back to my provider and say, hey, this is what the note said, this is what the patient feels. I personally don't want to treat this patient, but do you have any concerns?
Sure.
And there are certain populations, like your pregnant patient, those are the ones we have to treat.
Right.
Your neutropenic patients, those are the ones we have to treat. If they have any type of instrumentation and things of that nature, we didn't exchange the catheter. They require further assessment. So I don't want to generalize to those people, but for your general 23-year-old who comes in that could have went to the urgent care, but it came to the ED for something else, like those are the ones.
Non-specific abdominal pain.
Yeah. It's a host of things we have to look at. So that's kind of my practice when it comes to those patients. And then the next step is, okay, what are some myths that you would see when it comes to like the dipstick UAs? Because I'm pretty sure there's a ton of people who come in, they've already done like these at-home tests, and like trying to compare that versus what you're gonna get like a full workup and a full UA versus just that dipstick. How do you manage a patient that comes to you concerned about something, that non-specific symptoms, and they just say, oh, I went to the CVS and grabbed this urine dipstick or this UA, suppose, and they only get like one part of the entire UA and they want you to treat them?
Yeah, I think that's hard, and you just have to have a conversation of, this is an imperfect rapid test, and, based off of your symptoms, I wouldn't have even suggested that we test your urine, and really just have a good conversation with them. But it's hard. I mean, the culture in general is something is wrong, I need antibiotics. And don't get me wrong, antibiotics are this amazing thing that have, saved a lot of people, and I'm all about appropriate use of them. But having that conversation can be difficult, and just saying, like, I don't think that you need them. If you start to have symptoms, then potentially, we would treat that.
Yeah, and I think we skipped towards this earlier, but we talked about those unique cases that we actually would treat asymptomatic bacteria. But again, just to reiterate that, your pregnant patients, yours who come in neutropenic, those who has any instrumentations and the catheter has been changed, those are the people who we would treat or get further workup. I like to say that I'm not smart enough to treat those patients.
It is hard, right? Because realistically, the definition of asymptomatic bacteria is a positive culture. And when you're in the emergency department, you're like, cool, let me look in my crystal ball and see if your culture is going to come back positive. But you also, do want to appropriately treat high-risk patients. So it's kind of hard. But in general, if I see, a pregnant woman who has bacteria in their urine, I will treat them.
Yeah, and I think those are the slam dunk cases where there's like no pushback. The neutropenic patients, they're interesting because like those numbers change. Pregnancy is like 9 months. It's gonna be that, whether they're neutropenic or not, or they're getting treatment and it just improved their white count numbers. That's one thing. But I think just when I look at those patients, like, no, you're gonna get that if you haven't any treatment, and going from there. So those are the people who are a little bit more unique, and I don't want people to, give me hate mail and say you're not treating the right patients even if they're asymptomatic. So those are unique ones. So we talked a lot about the background. We talked about we probably the patient that we had before, we probably wouldn't treat that patient. But let's just jump into like, what are we using? What are the agents? Let's talk about drugs, and let's just break it down in a few pathways. We're going to talk about your uncomplicated cystitis, your uncomplicated pyelo, and then like all complicated issues, because realistically for me, when it gets complicated, I'm less involved in that process. So.
Right, me too, right? You're like, okay, someone's smarter than me at this point, because if it is complicated, and especially if they're sick, I'm like, great, I'm going to do broad, and then someone else smarter than me is going to narrow it down to the appropriate.
So let's just jump into like our traditional, just run-of-the-mill agents for your uncomplicated cystitis. Like, what do you like to use?
So I like to use either Macrobid or Keflex.
Yeah.
I love Keflex because, and I try to tell my residents this, whether they take it or not, is Keflex is great because it's safe in kids, it's safe in older people, it's safe in pregnancy, it's generally a safe medicine. Yeah. And for an uncomplicated UTI, it can be twice a day.
Yeah. So. And that's one of the caveats I think many people miss. So traditionally, you can see anywhere from 250 to 500. Q6, that's the LexiComp pharmacist answer.
Right.
That's the simple, but the 500 BID has been studied being beneficial as well. And I think, anecdotally speaking, I use it quite a bit, and I don't see patients coming back to us getting repeat culture because they failed Keflex. The interesting part is like for people who are looking at these cultures is that your culture won't say Keflex.
Right. The sensitivities.
Yeah, it would say, so it would say, NSAF or SAF, it would go down that route. But again, first generation, there's been some talk back and forth whether those cross over really well. And again, anecdotally, I haven't seen an issue. But if I see a patient who can get, cefazolin or if some of your cultures do show reflux, I want to make sure it's there. So sometimes you won't have it, but you can kind of extrapolate that a first generation cephalosporin, if it's sensitive across the board, and you may be able to give a PO oral cephalosporin. So that's a key thing that comes up quite a bit. And then for the macrobid, we're talking about 100 milligrams twice a day. Watching out for the discolored urine, because that freaks people out.
Right. You definitely have to tell people that.
Yeah, it freaks them out every time. And I think the other caveat that we have to look at is like their kidney function.
Sure.
That's the big thing, and I think the FDA's went from a GFR 60 to a GFR 45 mLs per minute. But I think that for our traditional run-of-the-mill healthy patient, it's a phenomenal agent. Yeah. Other things to consider is that some of our patients either they don't want to take capsules or tablets. I like Keflex because I know it comes in a solution.
I didn't know that. That's awesome.
So we use it commonly in pediatric population. And again, I haven't had many issues yet. So CVS, Walgreens, if you guys are getting scripts from my shop and you're mad, it's because I haven't had any issues when it comes to giving them something like that, and they can just take it as a very nice bubbly, bubblegum flavored solution. So those are like my two big ones. I would caveat that for certain patients, depending if there's like a question, if it's like pyelo versus gestacitis, I like augmentin as well, because I know it's going to penetrate well. It has good penetration in the urine. It's a phenomenal agent. It's twice a day. The problem I get is I don't want to give agents that are more than twice a day if I don't have to.
Right. Agents that are more than twice a day, agents that are super expensive. Yeah. It's just so much harder with people following through with compliance, which is understandable. I would hate to take a medicine 4 times a day. Yeah. And then I think that you brought up an important part too is what were their prior, what are their culture sensitivities or what are their prior culture sensitivities. So always double checking, does this person have a culture in the system that I can look at, and definitely only give them a medicine that their prior culture was sensitive to.
Yeah, and I think just looking at your different agents, the weird part about UTI, especially uncomplicated cystitis, is that depending on the agent you use, your duration kind of changes. And traditionally, we're talking about 3 to 5 days for the most part for these patients. So you don't need the 7, you don't need the 10 for your run-of-the-mill UTIs. And patients, you start to feel better in 2 days. Right. And there are some patients that I see come back the next day because they think that, I'm supposed to feel better now. The antibiotic's not working. And it's like, I have to reassure them hey, this is not an instant fix. Right. You're going to go home, you're going to take this, and then you go from there. Right. 2 agents that I want to caveat that I hate.
Okay.
I'm going to go ahead and just put this out here. If you prescribe a fluoroquinolone for uncomplicated cystitis with a patient that has no allergies, I'm going to track you down and I'm going to yell because they are horrible agents. We don't have to go down the rabbit hole of all the black box warnings, all the adverse effects from fluoroquinolones, and the fact that, even more importantly to me, they are, for the most part, resistant. They're the first thing that I see that's resistant on the culture. Yeah. So, and they also promote the resistance of other agents that are not even fluoroquinolones. So if we give them those, you notice the trend of, we started with fluoroquinolones, then all your beta-lactams became resistant as well. And I think 60% of women will have a UTI at some period of their life. And even a larger percent of those are going to have a recurrence of it. Right. So I would prefer, again, my docs to give a beta-lactam if you can. Sure. And it's usually what's the last thing on the list, and fluoroquinolones are that. My second agent, and I'm going to piss some people off with this one. I'm going to say it because it also falls on that pathway. I think Bactrim was a great drug 15 years ago. Mm-hmm. And the 3-day treatment course is great. Just give them that 1 tablet of DS and treat, twice a day for 3 days. It made sense then. Mm-hmm. The resistance patterns, again, locally, I work at 2 separate hospitals. It's always in the 60s. Yeah. So, again, there are certain people you can use it for, but your uncomplicated cystitis, those are the ones I'm like, if you don't have allergies, you don't have any other issues, it's going to be most likely resistant. And now looking at thousands of cultures, those are the first 2 things that come up resistant going to be your fluoroquinolone and Bactrim. And I know that's a little edgy, but I'm just saying if we had to pick our choice.
Yeah. I always am like, yes, very, it's clearly because of all the reasons you said, not for just other unnamed reasons, I guess. But I am always like, ooh, I don't Cipro, ooh, fluoroquinolones, ooh, Bactrim, ooh. Somebody has to. Sometimes they'll come and say like, I think we should do Bactrim, and I'm like, oh, okay, convince me.
Tell me why.
Like I'm never like, okay.
Yeah.
You know, it's not something that in my brain is like a green light.
Yeah.
You know what I mean?
Yeah, it's just, I feel like there's so many beta-lactams I can go to first before I go that route. That it's just challenging. And then seeing the cultures, I'm calling people back, hey, I'm sorry we sent you home on this medication. It's not shown to be the best one. Well, why did my doctor prescribe this? Well, it used to be a really effective drug. Unfortunately, the way we use it now, increase the resistance profile, and then it gets. We're not even talking about the side effects, the photosensitivity. We're not talking about the drug interactions that's going to have in people that have like kidney disorders or also taking ACE inhibitors. So that's something that comes as well. I had a patient, I would say a month ago, came back in fluor AKI, and I realized that he's on lisinopril. He was also taking another agent, and he was taking Bactrim, and that was the only change he's had. Hydration status and everything was fine for a period of time, but after he started Bactrim, it's like, yeah. So those are you mentioned my favorite drugs to use. I mentioned the one I hate, but those are the big ones. All right. And
then, from there, just check out your local antibiogram.
Yeah.
As to what you're trying to cover, which is usually gram-negatives.
Yeah, and I think we failed to mention I believe over 70% of what we traditionally see in these uncomplicated patients is going to be E. coli. That's going to be our big agent. And then the ones that play very similar to it, the Proteus, your Klebsiella, those are the ones that are the most common that I see. Can you get Pseudomonas? Yes, but it's usually another picture, and it gets into that complicated bracket where I'm calling someone smarter than me.
Sure, yeah.
So those are our big agents
for
uncomplicated cystitis. Now, let's move forward to pyelonephritis. Like, what does that patient look like? What are some key things that kind of clue you in, and how do you treat them?
Sure. So, pyelo, I would say, has to now be movement from just your bladder or urethritis and then up into the kidneys, right? And so then there should be some signs of systemic infection as well. So fever, chills, nausea, flank pain, all of those things. And, potentially in, again, those patients that come in kind of like altered, are they having altered mental status as a sequela of a systemic infection, right? And those people are treated differently, based off of risk factors. It's a young, healthy girl who otherwise is tolerating PO. Her pain is pretty well controlled. You can still potentially send them home with, strict return precautions of if you're not able to keep your antibiotics down. If it's starting to get worse, you come on back. But, in depending risk factors, depending kidney function, depending lots of things, they might need to come in for some IV antibiotics and IV, rehydration and all of that kind of, goodness.
And I think the agents really change a little bit for me when going from cystitis to pyelo. I'm thinking like what's something that penetrates a little bit more. That's when I get away from our phenomenal Keflex. I get more to things like augmentin. And if you look up the guidelines, it's going to tell us to use Cipro. It's going to tell us to do that. I understand if you're doing it for that patient. They also want us to use something like a ceftriaxone as a one-time dose and then move on to that. But it's something that we really have to think about all of our options. I use augmentin, ceftonir. It's another agent that I would use 300 milligrams twice a day, depending on their kidney function. It really just depends. But these are the more unique patients, I would say, because it's less likely that they get discharged, more so versus the observation just for a period of time, or they're going to actually go somewhere because they're like chronically and systemically sick, like you mentioned. So those are the ones a little bit more intriguing, I would say.
Yeah, I would say for the most part, if I think somebody has pyelo in the emergency department, I give them a dose of ceftriaxone and then admit them and have the inpatient team kind of go from there. But if they, like we said before, like otherwise totally clear to go home, want to go home, are comfortable with all of that, then changing the oral antibiotics to something.
Yeah.
Again, that's going to penetrate better, and macrobid's not going to work in this case, right? So.
That's the thing. Another agent that I will commonly see using, I'm actually using a lot more because my ID buddies would get on me from the ceftonir versus the cefuroxime. So cefuroxime, again, is another agent, the 500 milligrams twice a day. Mm-hmm. This is where we're treating a little longer. So these are the ones, the patients that between 7 and 10 days. I read a study recently that said that some of these patients can get treated for 7 days. But again, just knowing that you have that longer range there is going to be interesting.
I like that the cefuroxime is twice a day.
Yeah.
Anything that's twice a day is going to be so much better for compliance.
Yeah, and it's just, I feel like sometimes we prescribe these things and it's like, well, patient needs it, they'll be okay. And it's like, if you look at globally, how many of these people don't finish their antibiotics, it's a significant amount. Mm-hmm. These patients who are coming back and it's like, oh, it failed. Like, you didn't really fail. We failed you by giving you something that takes 4 times a day,
right?
And you failed to take them every single time like you needed to. Or there's any drug interactions, or there's some type of issues that go from there. So those are like my big ones. So I commonly see myself using a lot more Augmentin, cefuroxime, ceftonir, and bigger agents. And I'm a little more lenient, I would say, when it comes to the Cipros, because I get, if you look it up on UpToDate, if you look it up, it's going to say to use that. So those are our common agents. All right. Let's move from that to the complicated patient. It gets unique. So what does that complicated patient look like for you? Because realistically for me, that's when I see other teams getting involved. But what does that patient look like for you?
Sure. So I would say there's obviously a spectrum, right? There's the acutely ill septic patient. That person's a little bit more complicated, right? Because you're just going to treat them more broadly because you think maybe it's a urinary tract infection. That's the focus, but you might find later that they actually have something else going on. Then the spectrum, then kind of moving on from there to the patient who's had any type of urologic implementation. Right? Those patients are complicated. They always have dirty UAs, and it's hard to say what exactly is going on. They've had recurrent UTIs. They have drug resistance. They have all of these things that you're like looking through their old cultures, and you're like, I don't even know what the initial drug that I should give them is. And this is when I always phone a friend. I always phone you guys, and I'm like, hey, I'm looking through all these cultures, and I can't find a drug that is going to be, a safe, good medicine for them. To people with indwelling Foleys, to people with, renal trans, like all of those people who have either more complicated GU histories, or again are a little bit more acutely ill, I would say, all fall into that. I'm going to do my best, but I'm sure that the medicine that they're going to get moving forward is going to be decided upon by someone smarter than me. And
it's usually a team approach. My thing is I always say give ceftriaxone now if there's no allergies, and then figure out who's actually managing the issue down there in general. I had a few sicker pregnant patients that came in that was symptomatic. Those were, again, give ceftriaxone now, get OB involved. Your neurogenic bladders, your patients with those indwelling Foleys, again, they're going to be the ones who are going to be more interested in your males. Now, this has actually become a little bit more interesting in the past where we couldn't use certain antibiotics in males, but I think there's something that I won't touch on right now because I think someone smarter than me should to speak on that. But I think our antibiotics for those just get a little bit more broad, and that's where I think your unisins, your augmentins, again, just adding a bigger gun up front, and then figuring out what's more to do, because every day there's at least 2 patients on my culture list that's here all the time. They always grow something. It's always a very nasty bug. It's like ESBL, E. coli, or something, a space bug or something. It's just always very complicated. So for me, that's when I'm like, you call me, I'm like, okay, I think I can do this based off their cultures. If it takes me too long, I'm calling my ID buddies and I'm saying, hey, I recommend us just, again, give that ceftriaxone. Let's call urology. Let's figure out, a game plan on what to do. So we can do that. So I think that's really my approach when it comes to those complicated ones. And I don't want to get too deep into that because I really think that that's like a topic by itself. Getting deeper into that, I want to have someone like OB or urology or someone who's managed those patients quite frequently. So that's something to really get into. So we talked about a lot today. We talked about our asymptomatic patient up front that we're deciding we're not going to treat. We talked about the workup, the labs, the physical exam being key, the history being something, and then making sure we're ordering, like you say, you're ordering the UAs on the right patient.
Right.
Ordering cultures on the right patient. And then for our uncomplicated patients, we're talking about using agents like Caflex BID, 500 BID, using your cefuroxenes, your ceftonairs, and sticking away from Jimmy's hated drugs, Cipro and Bactrim. If you can. If you can't, I understand. And then realizing you have to kind of get a little bigger with Pylo, and then complicated, always call a friend.
Phone friend.
Yeah, just figure out someone smarter and going from there. Is there anything that we missed talking about in this episode that if you're attending on shift, someone's presenting a patient to you, what's something you want to know, or if they're treating that patient, what's something that you want to, some words of wisdom to give to your residents?
I would say my words of wisdom are really think twice before ordering something. Do you really think that they are having symptoms that are attributable to a urinary tract infection? Because if not, you can potentially cause harm to that patient. And then for that patient that's sort of in that gray area of maybe they're just a little dehydrated and that's causing them some confusion or some, feeling fatigued symptoms, to really have a good conversation or challenge you to have a good conversation with them of, I don't think it's really beneficial to treat this. But if it's not getting better, if you start developing symptoms, come on back or call your regular doctor, and do a good watchful waiting situation. We're not always equipped to do that in the emergency department, but I think it's worth the extra effort to potentially prevent harm.
Perfect. Yeah, I think overall, just looking at this, I think you just have to be intentional. Yeah. I think everything we're doing is being intentional about it. And then for a lot of my PharmDs that are doing culture callbacks, have that conversation, ask like, hey, what are you worried about? What's the big thing? Like, is there something else that wasn't documented? Do you remember seeing this patient? And then we can treat them if we need to be. What's their follow-up? What are all these additional things that can help us when treating a patient like this? So I think that's something that's unique, and I'm going to wrap it up there. I think that's really the big thing. Thank you for coming on. This is always special. I feel like all of our shifts, you're like teaching all day. And you just really just like, helping our students, helping our residents, really providing them with good advice. So I had to get you on the show and go from there. Any final words for you today?
No, thank you for having me. Thank you for helping me. Thank you for always, I call you all the time, and I'm always like, thank you. You, Kelsey, all the people in our farm are great.
Perfect. So
we appreciate you.
Shout out to Abby and Kelsey, my PharmD colleagues here at the U, I like to call it. Again, and just wrap everyone up. Again, guys, if you guys haven't had a chance to look at the Empower Conference, that was phenomenal. It was a really big experience. You guys really made that much bigger than I can ever imagine. So go check it out. If you want to just see the content and get the handouts, just go to empowerrx/conference.com. Or if you want to get CE, there's another area located there that's going to get you some CE. And if you like this type of stuff, you want more in-depth information, a lot of what I do is going to be in the PACU. Again, Pharmacy and Acute Care University. That's where, again, I have a master class that we're going to be doing on UTIs and get more in depth. If you want something or you want a live webinar or something like that, please just let me know. I'm probably the easiest pharmacist in the world to get in contact with. So just reach out, and I just thank you guys for listening to another episode. And you know how we close it out, guys. You don't have to be a pharmacist. You don't have to work in the ED, but everything you do, make sure you Pharm So Hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.
Perfect.